Welcome to Clinical Minute. Amelia and Mark come to see you after unsuccessfully trying to conceive for 3 years. Amelia is a 28-year-old bank manager. She tells you that she has severe dysmenorrhea and rates her pain as a 5 of 10 on good days and 10 of 10 on bad days. The pain typically begins about 1 week before her menses. She also reports that her menstrual cycles are regular, ranging from 24 to 35 days with premenstrual spotting. Amelia does not report bowel or bladder symptoms and denies pain with intercourse. Mark is a 30-year-old self-employed accountant. He is healthy and has normal seminal parameters. You obtain a thorough medical and social history from both Amelia and Mark. Neither of them reports a history of sexually transmitted infections, and Amelia indicates that she has had no previous surgery. She says that, "I never even had my tonsils removed, and I have always been really healthy. Now I am starting to think that I am not healthy at all because I can't get pregnant." The initial evaluation of a woman with chronic pelvic pain and suspected endometriosis includes a comprehensive history and physical examination. The history focuses on noting an accurate description of location, intensity, radiation, timing, and duration of the pain, as well as factors that exacerbate or relieve it. Medical history, including prior abdominal and gynecologic surgeries, as well as previous gynecologic problems. Social history, including sexually transmitted infections in the patient and her partners. You perform a physical exam on Amelia, including an assessment of her vital signs and a comprehensive examination of the abdomen and pelvic area. The pelvic and rectal examinations are the most important elements of the physical assessment. Signs of endometriosis include tender nodules in the posterior vaginal fornix, uterine motion tenderness, a fixed or retroverted uterus, or tender adnexal masses. When you examine Amelia, you note pain upon palpation of the uterus, and both ovaries are enlarged and immobile. You recommend that Amelia have a pelvic ultrasound, and she readily agrees. Transvaginal ultrasound is especially helpful to identify retroperitoneal and uterosacral lesions, but is less accurate in the identification of peritoneal lesions and small endometriomas. Computed tomography, or CT scans, can be informative following ultrasounds that are negative or inconclusive, but are rarely indicated for pelvic endometriosis and are not really cost-effective. Magnetic resonance imaging, or MRI scans, can be useful as an imaging modality for women with suspected deep infiltrating endometriosis, but also are rarely indicated. Estimates suggest that ultrasound, CT, and MRI are associated with a high false positive rate, and they lack the specificity and sensitivity to establish a definitive diagnosis of endometriosis. After ruling out other conditions, diagnostic laparoscopy for visualization and biopsy of lesions remains the gold standard for diagnosis of endometriosis. Keep in mind that not all lesions can be visualized at surgery. The treatment of endometriosis at laparoscopy depends on the skill and experience of the surgeon. Results from Amelia's transvaginal ultrasound reveal bilateral complex ovarian masses consistent with endometriosis. You refer Amelia to a gynecologist with clinical expertise in endometriosis and laparoscopic surgery for laparoscopic surgery. Surgery can be a more effective treatment for endometriosis and typically has a 20% recurrence rate within 5 years compared with a 50% recurrence rate for medical therapy. A laparoscopic approach is preferable to laparotomy because it decreases the likelihood of tissue trauma and allows substantial irrigation, which reduces the risk of postoperative formation of adhesions. Laparoscopy allows complete inspection of the pelvis with magnification. It also shortens the hospital stay and speeds recovery. The American Society for Reproductive Medicine has developed a classification system for endometriosis based on stage of disease. This classification system characterizes laparoscopic findings based on the extent of the lesions, density of pelvic adhesions, involvement of pelvic organs, and degree of fallopian tube occlusion. Points are assigned on the basis of these features, resulting in 4 categories including Stage 1 or minimal endometriosis, 1 to 5 points, Stage 2 or mild endometriosis, 6 to 15 points, Stage 3 or moderate endometriosis, 16 to 40 points, Stage 4 or severe endometriosis, greater than 40 points. After you receive Amelia's surgical report, you meet with Amelia and Mark to review the findings. They have already spoken to the surgeon, but ask that you go over the results with them again to help them understand their situation. You explain that the surgeon found bilateral endometriomas that are a type of ovarian cyst. The endometriomas were 6 centimeters and 3 centimeters in size. The surgeon was able to remove the endometriomas with 50% of the left ovary and 80% of the right ovary retained. You explain that this is good news because it means that Amelia is still able to ovulate. You also tell them that both fallopian tubes were found to be patent or unblocked. You explain that these findings indicate that Amelia has stage 3 or moderate endometriosis. Upon hearing this news, Amelia begins to cry and Mark takes her hand. Both are visibly distressed and Mark asks, "So what does this mean for our chances to have a baby?" You clarify for Amelia and Mark that while there is substantial evidence to suggest an association between endometriosis and infertility, there is no evidence at this time to establish a causal relationship. You also explain to Amelia and Mark that the stage of endometriosis has not been shown to correlate with pain severity, risk of infertility, or the ability to conceive following treatment. A retrospective analysis of 393 consecutive patients who were undergoing treatment for endometriosis revealed that, overall, 91% of the women had symptoms of chronic pelvic pain and 85.4% had infertility with or without pelvic pain. Infertility rates did not consistently increase with higher stages of endometriosis. Amelia and Mark turn to you and say, "What do we do next? Is there a medication that Amelia can take to help her get pregnant?" You explain that medical suppressive therapies such as continuous combination hormonal contraceptives and GnRH agonists are not effective for the treatment of infertility caused by endometriosis. Furthermore, pre- and post-operative medical therapy does not improve fertility and may, in some cases, delay fertility. You explain that surgical management has been shown to improve pregnancy rates, but the magnitude of improvement is not yet known. You tell them that surgical treatment of minimal and mild endometriosis is associated with a 65% increase in post-surgery conception. Advanced endometriosis is more difficult to manage, with a low pregnancy rate following surgery. However, you explain that Amelia's procedure, excision of endometrioma, is more effective than drainage and ablation of the cyst wall, with a pregnancy rate of 60.9% for excision versus 23.4% for the less aggressive intervention. Based on the fact that Amelia is young, 28 years old, you suggest that she and Mark try to conceive naturally for the next year. If they are unsuccessful, you indicate that you would be happy to discuss in vitro fertilization, or IVF, with them, or refer them to a fertility specialist if that is their choice. Women over 35 with endometriosis-related infertility also should be offered referral for IVF. Amelia and Mark schedule a follow-up appointment with you 1 year after the laparoscopic procedure. They explain that they have tried to get pregnant without success and that the usual way just isn't working. They ask for information about IVF, saying that it is important to them to start a family while they are young, in good health, and have the energy to care for children. You refer Amelia and Mark to an IVF unit for a stimulated IVF cycle. 6 oocytes are retrieved, and 2 embryos are successfully transferred to Amelia. Amelia goes on to have an uneventful pregnancy and deliver a healthy baby boy by cesarean section. Amelia and Mark schedule an appointment to introduce you to Theodore. They are beaming with happiness as they walk into your office holding their baby. They tell you that we always knew we were meant to be parents, and having Theo has confirmed it. Thank you for your help over the last 18 months. We are delighted with our miracle baby.